Welcome, fellow Brainiacs. It's great to see you. For those new to the channel, my name is Dr. Martin Rutkowski, and I'm an assistant professor of neurosurgery with expertise in brain tumors. In today's video, I'll be reacting to med school insiders, so you want to be a neurosurgeon. But before we go any further, be sure to like and subscribe, and don't forget to turn on the notification bell so you don't miss any future videos.
So you want to be a neurosurgeon. After all, it's super badass, second only to being a rocket surgeon. Let's debunk the public perception myths of what it means to be a neurosurgeon and give it to you straight. This is the reality of neurosurgery. Dr. Jabal, MedSchoolInsiders.com. Welcome to our next installment in So You Want to Be. In this series, we highlight a specific specialty within medicine, such as neurosurgery, and help you decide if it's a good fit for you.
So I want to take the opportunity to give a big shout out to Med School Insiders and Kevin Jabal in particular. It's very clear that they put a lot of time and energy into these videos, and I think this one on neurosurgery is no exception. It has a lot of really valuable information and insights, and overall, I'm a big fan.
Find the other specialties on our So You Want to Be playlist. A lot of you asked for neurosurgery in our poll, so that's what we're covering here. If you want to vote in upcoming polls to decide what future specialties we cover, make sure you're subscribed. If you'd like to see what being a neurosurgeon looks like, check out my second channel, Kevin Jabal MD, where I do a second series in parallel called A Day in the Life. We'll be doing a day in the life of a neurosurgeon soon, and you don't want to miss it.
So I know that a lot of you are curious about a day in my life, and I am intending to put out a video in the near future on this topic. It takes a fair bit of coordination, but I do want to give you all an honest and open look into what my life looks like, so stay tuned, that is coming up.
Neurological surgery, or neurosurgery for short, is much more than just brain surgery. The nervous system is comprised of two main components, the central nervous system, or CNS, and the peripheral nervous system, or PNS. Try saying that one 5 times as fast as you can. The CNS includes the brain and spinal cord, whereas the PNS includes all other nerves within the body. Neurosurgery deals with surgical interventions of both.
While it is true that there are a subset of neurosurgeons who focus almost exclusively on the peripheral nervous system, in general that tends to be fairly rare. You'll find these neurosurgeons mostly at academic medical centers, and there is a separate fellowship that you can do to train specifically in those disorders. But for the most part, you'll find that neurosurgeons typically focus on either the brain or the spinal cord.
There are two overarching categories to neurosurgery: elective surgery and emergent surgery. Elective surgeries take place on a non-emergent basis and generally involve treating conditions that are not immediately life-threatening. They tend to fall into one of 3 categories: cranial surgery, spine surgery, and peripheral nerve surgery. Cranial surgery, as it sounds, involves operating on structures within the head, such as the brain. This category can be further subdivided into a few more subcategories: tumor surgery, vascular surgery, and functional neurosurgery. Tumors in the brain come in all shapes and sizes. They can be benign or malignant, slow or fast-growing, life-threatening or not. Some tumors can be observed without ever needing treatment, while others can be treated with radiation. But often, given the limited space afforded by the human skull and the sensitive nature of the brain's tissues, a neurosurgeon is called upon to surgically resect a tumor in the brain.
For the most part, Kevin's really hitting the nail on the head here. For tumor neurosurgery, it's really important for us to know exactly what we're dealing with. Characterizing the behavior of a tumor depends completely on the pathology. So while a certain tumor can cause a variety of different problems or neurological deficits in a patient, it's really hard to understand what the prognosis is and what the possible treatment options are without actually having tissue. So in addition to removing a tumor to actually relieve symptoms or improve a patient's overall prognosis, we do often need to establish what the diagnosis is. And so performing a resection or removal of a tumor also accomplishes that goal.
Vascular neurosurgery involves treating abnormalities in blood vessels of the brain. Neurosurgeons might treat an aneurysm on a vessel, or bypass a blockage or narrowing of a vessel, much the same way you would do coronary bypass on the heart. Functional neurosurgery is the sexy stuff, the science fiction of the field. In functional neurosurgery, the brain is viewed as one large, complicated electrical circuit, and neurosurgeons try to modulate the circuit to bring about a desired outcome. This might involve placing electrodes within the brain to stimulate certain structures, or creating lesions with radiation, ultrasonic energy, or simple thermal ablation to effectively turn off structures that might be causing problems for a patient.
Even though I'm not a functional neurosurgeon, I couldn't agree more. To me, this represents one of the most exciting areas within neurosurgery. And what he hasn't mentioned would be the rapid development of machine-brain interface and neuroprosthetics. Imagine the following example. You've got a patient who's paralyzed or unable to speak. Now imagine that we could insert electrodes, either on the surface or deep within their brain, that could decode the very electrical activity that allows the brain to function. Now, instead of losing that ability that they previously had, a computer could decode those thoughts and either produce words on a screen or movements in a robotic arm, thereby reestablishing functions that we had no option to treat before. So this type of work, which is being done in research applications, to me represents some of the most exciting frontiers within neurosurgery, let alone medicine as a whole.
Within spine surgery, there are a few subcategories as well. We'll call them degenerative, scoliosis, and tumors. The vast majority of spine surgery is done to treat good old-fashioned wear and tear or degenerative disease of the spine. Within these degenerative processes, the spinal cord itself, or nerve roots exiting the spine, can become compressed, leading to pain and weakness. Surgeons often are required to decompress these structures by removing certain elements of the spine. When removing these bony arthritic spurs or degenerated discs, the integrity of the spine can become compromised, which can require a spinal fusion to restore stability, although the fused segment has increased rigidity. Spine surgery also includes repair of scoliosis, whereby curvature of the spine can become so severe as to cause pain, difficulty breathing, or other functional deficits.
This section highlights a really important point, especially for anyone considering a career in neurosurgery, and that is that most neurosurgeons focus on spinal neurosurgery. Think about the people in your life. How many people do you know with back or neck problems? Probably far more than those with brain tumors, movement disorders, or even cerebral aneurysms. So by the numbers, it makes sense that most neurosurgeons will have a practice that focuses predominantly on spine.
It's important to note that spinal decompression surgeries and scoliosis repair can be performed by either neurosurgeons or orthopedic surgeons. However, removal of tumors of the spinal cord is performed exclusively by neurosurgeons.
While it is true that your choice of training, whether in orthopedics or neurosurgery, can affect to a certain extent the type of spine surgery practice you'll have, for the most part we end up ultimately at the same location. I've seen excellent spine surgeons in both orthopedics as well as neurosurgery. In regards to tumor spine surgery, it is true that neurosurgeons almost exclusively are the ones to operate on tumors that actually occur within the spinal cord itself. That being said, there are a number of tumors that can affect the spinal canal and the bones within it that are treated more often by orthopedic surgeons, such as tumors that arise in the sacrum. So no matter what you want to do, either path is probably an excellent way to get there. And thankfully, throughout my career, I've much more often seen collaboration between departments of orthopedics and neurosurgery than I have confrontation. So these tend to be excellent relationships. Ultimately, we're treating a very similar patient population, and so that makes for good friends and excellent colleagues.
A tumor in the liver or breast can be relatively quickly resected. Removing tumors around the spine can be quite involved and take a long time, even for small tumors, due to the care and precision required to leave the spinal cord uninjured. Peripheral neurosurgery, as the name suggests, involves operating on the peripheral nervous system. This includes all nerves outside of the brain and spinal cord. These nerves can sprout tumors or become injured in an accident. In such cases, a neurosurgeon may be called upon to remove that tumor, to reconnect severed nerves, or in some cases, to connect part of a healthy and working nerve to a damaged nerve in the hopes that a patient can regain function of that nerve over time. Now, if you're a trauma surgeon, you take shifts and handle traumas that come in on your shift. If you're a neurosurgeon, you have to operate on your scheduled cases, but also take neurosurgery trauma call on top.
This is true, but a little bit misleading. As neurosurgeons, we know when we're going to be on call, and we do have a fair bit of control over our elective schedule. So it's certainly possible to shift around cases or avoid operating on certain days if you know that you're either going to be on call or even post-call. So while it is true that our schedules can often get very chaotic, we do have a little bit more control once you reach the faculty or attending level over that type of schedule.
It's just part of the job. Compared to other parts of the body, the skull is a fixed space, which results in its own set of issues. If you bleed into your abdomen, you're concerned about exsanguination, meaning you can bleed out and die as your abdomen can distend to accommodate a large volume of blood. In the cranium, however, a fixed space means that as you bleed, pressure increases, resulting in compression of the brain. You won't ever exsanguinate, as the skull is too small, but brain bleeds are deadly due to brain herniation, meaning compression and pushing of critical structures through the foramen magnum outside the skull. Alleviating pressure is key, and this is done with a decompressive hemicraniectomy, meaning removing part of the skull to create space for the brain to swell after it has been injured. The excised segment is kept in the freezer, and neurosurgeons can put it back weeks or months later when the brain swelling has resolved.
While a decompressive craniectomy is a very good way to relieve increased intracranial pressure, it is important to note that we often have a number of other options that we can use before undergoing this large operation. So for example, you can oftentimes do a smaller craniotomy or opening in the skull to actually remove a blood clot or a lesion that's causing mass effect or pressure within the head. So we don't always have to jump to a full decompressive hemicraniectomy. But it is true if you do any form of trauma neurosurgery, this is a surgery that you're probably going to do fairly often.
There are 4 main types of brain bleeds: epidural hematomas, subdural hematomas, subarachnoid hemorrhages, and intraparenchymal hemorrhages. Epi means above, and dural refers to the dura, the outermost layer of the meninges covering the brain. Epidural hematomas are bleeds most commonly from the middle meningeal artery in the space below the skull but above the dura. With an arterial source, these bleed quickly and usually result from blunt trauma to the head. Subdural hematomas are below the dura and are more common amongst elderly patients on blood thinners. These are venous bleeds and slower in nature, but can be equally urgent and life-threatening. Subarachnoid hemorrhages result from an aneurysm rupturing, and because it's below the arachnoid layer of the meninges, the blood fills the sulci of the brain, meaning all the nooks and crannies, effectively coating the brain in blood, which can be toxic. Intraparenchymal hemorrhages are bleeds within the actual tissue of the brain, and this can result from long-standing hypertension resulting in arteriosclerosis or other reasons. Ruptured aneurysms are usually handled by neurosurgeons, but sometimes by endovascular surgeons or interventional radiologists.
The treatment of cerebral aneurysms becomes more and more nuanced with the advent of new techniques that can be used, such as stenting or coiling. I am seeing 2 shifts that I think are important to mention if you're considering a career in vascular neurosurgery. Number 1 would be the slow and gradual movement away from open craniotomy for aneurysm clipping, more towards endovascular techniques for aneurysm coiling and stenting. That also means, however, that number 2, more and more specialties are coming to the party. Specifically, neurointerventional radiologists as well as neurologists are increasingly being trained to treat cerebral aneurysms. So expect that if you're interested in a career in vascular neurosurgery, there may be a little bit of competition between these services.
Treatment is either coil placement or placing a clip over the aneurysm. Intraparenchymal hemorrhages can sometimes be large enough that they need to be evacuated. In those cases, a neurosurgeon might make an opening into the skull and work their way down to the hematoma to evacuate as much blood as safely possible without damaging surrounding structures. If a patient fractures their spine, the spinal cord can become compressed or even severed. Urgent decompression is often required, as is stabilization to reduce additional uncontrolled movement and further injury. This is why you see C-spine collars placed on trauma patients for stability and to reduce the risk of additional spinal cord injuries. To become a neurosurgeon, you'll have to complete neurosurgery residency after medical school. Neurosurgery has the longest residency start to finish, lasting 7 years in duration. Most residencies will include 1 year of dedicated research time, though not all.
Neurosurgery residency is not only the longest, it also can be the hardest, and so it's important to go into the process with open eyes. While it is certainly competitive and difficult to actually get into neurosurgery residency, your work has just begun. So you need to understand that there's going to be a fair bit of sacrifice if this is in fact a career that you want to go through. But as you know, I like to say that anything worth doing is worth a fair bit of sacrifice. And in the case of neurosurgery, there's going to be a lot of sacrifice. But ultimately for me, it was very much worth it, and if I could do it all over again, I'd do it in a heartbeat.
In terms of competitiveness, neurosurgery is consistently in the top 5, in most recent years being ranked 3rd only behind dermatology and plastic surgery. Neurosurgery candidates are top students with very high Step 1 and Step 2 scores, generally only a few points below the average dermatology or plastic surgery matriculants. But what truly sets neurosurgery applicants apart is their research. The average matriculant in 2018 pumped out over 18 publications, abstracts, or presentations by the time they applied to residency.
As Step 1 moves from a numerical system now to a pass-fail system, I am getting more questions about how this is going to affect the residency selection process, and that is a good question. Now, the truth is that in my experience with where I trained, in general, once you reached a certain range of score, we didn't care so much about what your actual number was. Now, obviously, you might stand out if you were at the upper or lower end of average, but in general, within that range, we started to focus more on other things like clinical characteristics such as your performance on rotations, number of publications, and quality of publications, as well as letters of recommendation. And this is a really important part of this video that Kevin really hits on. It is true that neurosurgery applicants on the whole tend to have more publications, but to me, quality matters far more than quantity. If I encounter an applicant who clearly has just published case reports and tried to get their numbers up, that doesn't impress me nearly as much as, let's say, a PhD or a student who's taken time off to focus specifically on an area that they're passionate about. That always shines through, and that's what I would encourage you all to do.
In comparison, plastic surgery and dermatology were at 14, with orthopedic surgery at 10. Most other specialties didn't even break 7. So why the focus on research in neurosurgery? Neurosurgery is a highly academic field, likely due to the fact that there is so much room to improve outcomes in patients. Residency programs want to train surgeon scientists who will advance the field. While treatment modalities and outcomes have improved drastically in the past 20 to 30 years, there are several pathologies with bleak outcomes. For example, glioblastoma multiforme, or GBM for short, had an average prognosis of about 5 months over a century ago. Despite all the technological advancements since, these days, even after aggressive surgery, radiation, and chemotherapy, median survival has improved to only 14 to 16 months.
While the overall numbers may in fact be a little bit better than what he's quoting here, it is true. Glioblastoma remains an incredibly difficult disease to treat and one that I see very frequently. Overall, it feels like it's emblematic to me of the larger issue that we have within neurosurgery, which is that we treat serious and devastating diseases that are in serious need of scientific research. And that to me is a huge part of the reason why we focus so much on residency applicants with an aptitude and interest in research. We not only need brilliant minds with gifted hands, but we need people with fresh ideas. And so continuing that culture and focus on research is a very important part of being a neurosurgeon.
Medical students that end up applying to neurosurgery are a unique bunch and are a self-selecting group. They take the meaning of workaholic to the next level. The award for most brutal and rigorous residency, even amongst surgical residencies, is usually reserved for neurosurgery. Despite the 80-hour workweek restrictions enacted by the ACGME, it's not uncommon to see neurosurgery residents exceeding these limits repeatedly.
No comment.
After completing residency, you can practice as a general neurosurgeon or choose to subspecialize further with a fellowship. Skull base is primarily concerned with tumors that grow along the base of the skull, which is notoriously high-end real estate. It's a shrinking field, mainly because less invasive options like radiosurgery and endovascular procedures are becoming more sophisticated and appealing for patients.
Now this is probably the first part of the video that I found to be completely wrong. Now, obviously, as a skull-based surgeon, this is near and dear to my heart, but it is important to note that the field is growing and not shrinking. Even though we have more modalities that are non-surgical to treat lesions or tumors that arise between the base of the brain and the skull, the introduction and application of endoscopy or camera-assisted surgery has completely revolutionized what we do in skull base. So overall, skull base is growing and not shrinking.
Those with the best hands and stamina for 18-hour plus surgeries go here. It's a young man's game. Neurovascular is highly technical, dealing with aneurysms, hemorrhagic strokes, and bypassing blockages in the brain. Call schedule is brutal, attracting those who are gluttons for punishment. Outcomes can sometimes be particularly grim, which can take a toll over the course of one's career. You'll need a strong stomach.
A big part of the reason why your schedule can be so crazy as an endovascular neurosurgeon is the fact that we now have clinical trial data demonstrating a definite benefit to something called mechanical thrombectomy, which is endovascular removal of blood clots that can cause stroke. With tons and tons of strokes worldwide, that means that if you're on call, there's now a much larger patient population that stands to benefit from your services. So while this can be good because it certainly means that you're going to be busy and helping a lot of people, it can make for some pretty busy calls.
Functional and stereotactic surgery deals with modulating the electrical circuitry of the brain. These are the nerds of the nerds, usually with PhDs after their name or computer science backgrounds. Spine is for the jocks and ortho bros. There's a great deal of bony work, thus requiring a higher degree of strength and, on average, less finesse than other aspects of neurosurgery.
I'm going to take issue with some of these characterizations here. I think they're a little bit lazy and reductionist. If you go out and meet 100 neurosurgeons, I guarantee you'll find 100 different personality types. And while it may be true that certain personality types cluster within certain specialties, there are always exceptions to the rule. You might be surprised in some ways at how functional neurosurgery can be very simple and straightforward, and how elegant and nuanced spinal neurosurgery can be, in particular deformity cases where you're rebuilding someone's back or neck. So there are certainly exceptions to the rule. And the best thing for you to do is to experience them yourself. Meet a neurosurgeon, see what their practice is like, interact with their patients. That is the best way for you to determine whether or not something is right for you. Ignore the stereotypes and just throw them out the window.
Pediatrics is for the neurosurgeons who are best at dealing with parents. A strong stomach is prerequisite, as children needing neurosurgical intervention generally don't have rosy outcomes.
This is an oversimplification and mostly incorrect. While it is true that there are a number of terrible conditions that can affect children and lead to poor outcomes, for the most part, a huge part of the reason why pediatric neurosurgeons enjoy their job is because of the capacity of children to heal and to recover. The other thing to remember about pediatric neurosurgery is that they pride themselves on the ability to operate on the brain, the spinal cord, and the peripheral nerves. So if you don't want to give up operating on just one part of the central nervous system, pediatric neurosurgery may be for you. There's an incredible capacity to change the lives of young patients and affect their lives forever. So if that's something that appeals to you, I would encourage you not to focus so much on the negative outcomes, because those are present no matter what you choose in neurosurgery. It's an incredibly rewarding field and does require some finesse with parents, but ultimately I would think that pediatric neurosurgeons are some of the happiest people that I know.
Peripheral nerve is perhaps the smallest subspecialty within neurosurgery, partly because it's not exclusive to neurosurgeons, as you can get there through orthopedics or plastic surgery as well. It's for surgeons who enjoy operating all over the body, since the peripheral nervous system exists everywhere outside of the brain and spinal cord. Surgical neuro-oncology tends to attract surgeons with an interest in tumor biology. These surgeons may spend up to half of their time in the research lab, studying additional methods for tumor treatment beyond simple surgical resection. This is because a large subset of brain tumors don't respond to just surgical resection, like GBM.
Now this is true, and I would say that a fair number of neurosurgeons with a focus or specialty in surgical neuro-oncology do also have a strong research component to their career. And I would argue that most of them see that as a strength. We understand that cancer is not a disease that can just be cut out or treated surgically, and so the development of therapeutics, medications, chemotherapy, etc., that target the residual tumor that we can't access surgically is an important part of our career goals. So if that's something that you find rewarding, I would encourage you to check out surgical neuro-oncology.
Trauma and neurocritical care is for those surgeons who wish to focus on the multidisciplinary treatment of patients with traumatic neurological injuries. Beyond performing life-saving surgeries, these folks are interested in the longer-term post-operative recovery process for patients suffering from traumatic brain injury, spinal cord injury, aneurysm rupture, or hemorrhagic stroke. As a neurosurgeon, you'll be working on arguably the most fascinating and mysterious organ in the body, the brain. Psychiatrists and neurologists deal with the brain as well, but in a non-surgical capacity. You'll get to touch, change, and augment the central nervous system right in front of you in real time. It's a highly innovative field, particularly the subspecialty of functional neurosurgery, where the line is blurred between what is you and what is hardware. It raises questions about free will, consciousness, and other questions that are bound to keep you up late at night. Only a few specialties truly save people's lives, and neurosurgery is one of them.
When people ask why I put up with the long hours, the stress, the incredible demands of the field, these are the reasons why. The opportunity to save someone's life or significantly change it, it's absolutely a privilege. There's nothing that I'd rather do, and this makes all of the hard work worth it. So for those of you considering the field and feeling somewhat daunted by the long path ahead, I can tell you that at the end, it's completely worth it.
And while the surgeries may become routine, the feeling of saving someone's life never will. Trauma and emergency medicine are some other specialties that share this aspect. Neurological surgery is a highly academic field, satisfying even the most intellectually curious. You'll be surrounded by driven and truly impressive colleagues cut from the same cloth. To quote my neurosurgery friend, not to say we're better than everyone, but we are. He's joking, of course, but not really. As a doctor, you normally need to choose between honing surgical expertise and foregoing medical management, or vice versa. That's one thing I did not enjoy about plastic surgery. I wasn't managing patients medically so much, just more so surgically. As a neurosurgeon, you'll be handling the medical side of things too, titrating sedatives to adjust for intracranial pressure abnormalities, adjusting ventilator settings, and reading EEGs to see if someone is seizing. In medical school, I rotated on orthopedic surgery, plastic surgery, and neurosurgery, the 3 specialties I was considering most seriously. One thing I loved about neurosurgery were the personalities. Some of the funniest and coolest surgeons I worked with were, of course, neurosurgeons. This is not uncommon. The field is very humbling, and despite the stereotype, neurosurgeons are faced daily with the reality that they are not God. You cannot take yourself too seriously, and you will need to learn to laugh at yourself, otherwise you won't last. There were 2 main factors that pushed me away from neurosurgery, despite my love for neuroscience and my fascination with the brain. First, think about the types of patients that need neurosurgical intervention. They're very sick and can often have very poor outcomes. Many patients succumb to immense suffering or death. That may not sound so bad right now, but day after day, year after year, that sort of heaviness will weigh on you.
So the exact reasons that he chose not to go into neurosurgery are in fact the reasons that I chose the field. I love the sense of responsibility in taking care of critically ill and very, very sick patients. And in fact, that's a huge part of the reason why I chose to go into brain tumors. I love giving patients a sense of optimism and positivity about what can be a very dire situation. So instead of looking at it as a negative, as something that'll maybe wear you down emotionally, to me, it's a call to action. I love instilling hope and optimism, and to me, that's one of the best parts of the field.
The other thing that pushed me away from neurosurgery was learning that it wasn't as precise and meticulous as I would have expected brain surgery to be. Certain aspects are highly precise, like skull base, but much of neurosurgery is surprisingly crude and closer to something like orthopedic surgery rather than plastic surgery.
When I first heard this, it drove me absolutely crazy. In my opinion, nothing could be further from the truth. No matter what surgical specialty you choose, you're going to find examples of operations that are simple and straightforward, maybe even crude, and examples of surgeries that require a high level of technical precision and accuracy. And in my opinion, neurosurgery is full of those. Whether you're operating on the brain, the spinal cord, or the peripheral nerves, you will find examples of beautiful operations that abound. And a huge part of that is because much of what we do is operating under the microscope. So using a high degree of magnification automatically requires a high level of technical precision. And to me, nothing beats it. A well-executed operation in neurosurgery is like a beautiful symphony. And while I may certainly be biased as a neurosurgeon, in particular as a skull-based surgeon, I have to take exception with what he says here.
But wait, there's more. Neurosurgeons face one of the most challenging lifestyles of any specialty, even beyond residency. That's because in addition to your scheduled cases, you'll need to take neurosurgery trauma call. In medicine, we say that neurosurgeons make the most money, but don't have any time to enjoy it.
This again is a bit misleading. It all depends on the career you choose, whether or not you go into academics, privatemics, or private practice, and what specialty you choose within those can completely determine your schedule. I know some neurosurgeons who only work a couple days a week, and some who work 8 days a week. So it completely depends on what your career goals are, but there's a lot of flexibility. And remember, when choosing neurosurgery, work-life balance really shouldn't be your primary concern. And I would argue that that's true of any specialty you choose. No matter what you do, chances are you're going to spend most of your time in that profession, so choose something you love for what it is, not for the work-life balance it potentially gives you.
The median salary is $680,000 per year, and they're consistently number 1 or number 2 in terms of highest paid specialty, duking it out with orthopedic surgeons. The field is 92% men. While not as bad as orthopedic surgery, it's one of the most male-dominated specialties, although that is slowly changing. The neurosurgeon stereotype comes with good and bad. For online dating apps, it's great, but beyond that, the stereotype is difficult to deal with in the hospital. Others expect you to have a god complex, to be an asshole, egotistical, emotionless, or even sociopathic.
I think this is a little ridiculous. Rather than worrying about some made-up stereotypes, why not focus on your actual character and who you are as a person? I think that matters a whole lot more, and will go way farther in influencing what people think about you than worrying about silly stereotypes that they may have heard instead of actually judging you based on who you are. Be a good person, and the rest will take care of itself.
At this point, you'll know whether or not neurosurgery is right for you. It's a highly self-selecting group of people. Obviously, you need to enjoy the practice of surgery and have deep intellectual curiosity for the brain and mind. But beyond that, you need to really want it more than anything else. You'll need incredible stamina to endure a brutal 7-year residency and continue to work challenging and unpredictable hours as an attending. The stakes are high, and there's a consistently high sphincter tone and level of vigilance. That's because so often, patients with neurological injuries can be incredibly hard to monitor. A patient in acute organ failure, mid-heart attack, or exsanguinating during a trauma can be hard to ignore. But in neurosurgery, potentially devastating neurological complications, such as a stroke or a brain bleed, can occur with scary subtlety. Being on top of the ball is a must. If you're all about that, you'll certainly get the excitement and rush from the unpredictability of trauma. You'll also get the highly technical aspect of something like plastic surgery.
And neurosurgeons are the ones who are supposed to have big egos? Just kidding, Kevin.
If you take deep pride in your work and have perfectionistic tendencies, neurosurgery may be a good fit. Big shout out to the neurosurgeons at Med School Insiders who helped me in the creation of this video. If you are interested in becoming a neurosurgeon yourself, you'll need to be a top performing student. And who better to learn from and be mentored by than neurosurgeons themselves?
Neurosurgeons like me and Martin Rutkowski, MD. Be sure to check out all the other videos I have on my channel, and you'll find a wealth of information about applying into residency, succeeding as a neurosurgeon, and what it takes and what it's actually like.
If you need help acing your MCAT, USMLE, or other exams, our tutors can maximize your test day performance. If you're applying to medical school or neurosurgery residency, our neurosurgeons can share the ins and outs of what it takes and how to navigate the highly competitive process most effectively. Learn more and see why our customers love us at medschoolinsiders.com. Thank you all so much for watching. This one was particularly fun to make.
And particularly fun to react to. Big shout out to Kevin Jabal, MD, Med School Insiders. Thank you again for the opportunity to react to your video, and thank you all for watching, those of you who have made it this far. Appreciate it, and I'll see you next time.